The World Health Organization says that 1 in 3 women worldwide has experienced physical or sexual violence at least once in their lifetime, and much of that violence comes at the hands of an intimate partner. To better understand what that means and what can be done about it, we're joined by Dr. Mohit Bhandari, Professor of Orthopedic Surgery at McMaster University and Honorary Chair of Mentor Action in Hamilton, Ontario, and Clare Freeman, a domestic violence expert and Executive Director of the Dr. Bob Kemp Center for Hospice Palliative Care. Welcome to the both of you.
Thank you for having us.
Before we start talking about the next half hour, I wanted to talk about some of the terminology. Clare, can you clear up some of the terminology? Is it domestic violence, intimate partner violence?
I think it depends on the sector that you're in and also the framework in which you come to the issue. So certainly in healthcare, they call it intimate partner violence. The World Health Organization calls it intimate partner violence. It's a gender-neutral stance. Certainly women's advocates, violence against women advocates would call it violence against women or gender-based violence. Old terms that still exist, people call it battering. Some people will call it relational violence. So I mean, I think what everyone looks at is the fact that we have people who are in intimate relationships that are being abused in some place, sexually, psychologically, emotionally, and it's just really how you frame it.
And why is it important to get the terminology right?
Well, I think depending on, again, your sector and what you're looking at, then you're going to look at it in a different way. And so I think that for violence against women experts, we really want people to look at the gender aspect of it, because we certainly know when we talk about violence, it's generally women who are dying in intimate partner violence, and the main perpetrator is generally men. We know that when you look at even GLBTQ relationships, there's some differences in the gender there as well.
And Mo, how did you get involved in combating gender-based violence?
Sure. I trained as an orthopedic surgeon, and around 2005, I went to the U.S. and I was doing some subspecialty training in fracture care to bring those skills back to McMaster University. My partner, Sonia, is a social worker, and so she was working at that time at the Domestic Abuse Project, which was focusing again on injuries in women coming in, for treatment, and obviously they're strong advocates of supporting women in abusive relationships. She would come to me and say, with these pretty serious injuries and asking all these kinds of details about fractures, and that led to a discussion around, well, are these same women who you're seeing coming in like really within a mile radius of where a hospital is, are they coming to our clinics? That led to a discussion of really exploring the injury patterns, the physical injury patterns that surgeons might see. And these are serious injuries. These were dislocations, broken bones, pelvic fractures, things that would definitely have gone through an orthopedic surgeon's practice. That led to a discussion which ultimately led to an interaction with Clare, when I came back to Canada, and ultimately led to us doing a lot more research and, quite frankly, trying our best to make this topic the #1 advocacy issue in the Canadian Orthopedic Association.
And when do you think, did you have like that aha moment that you needed to do this kind of work?
It was in 2000, I can almost remember the day. It was, Sonia had come to me and she said, what is a humerus fracture and how serious are they? And I kept saying, well, jokingly, I said, you don't really ask me about what I do for the last 10 years. You're asking now, right?
Yeah.
Right? She's asking now, like, why? And so she said, well, I need to know because of some women I'm dealing with. That led me to go back to our surgeon who said, Mo, it's a non-issue. We don't see it in our practice. And that was the disconnect right there, which is, how can that be? How can there be, in this case, 262 women with injuries in a neighboring institution right beside the hospital, and they all said that they've seen by physicians, and you're saying that none of this happens. And that was a disconnect that led to something has to happen, something has to change, and it's unlikely to change unless we start, getting a group of people together to start talking about the issue. The biggest thing is silence. Silence has been the challenge.
Silence from the victims or from like the professionals, or?
Well, I think it's two. I think it's professionals just simply not acknowledging that this is an issue. And often what happens is, well, if it's happening out there, not in my clinic. And quite frankly, if it is in my clinic, it's really not my issue. There are social services available. The hospital has all these other, safety guards that for sure, that me as the healthcare provider doesn't need to be engaged in the same way because someone will take care of it. And that has been this issue I believe, from many women that we've had the interaction with. You know, a big part of it is they're silenced by the fact that, you know, no one's going to listen. Or what's the point of going through this process when I know I'm not going to ultimately receive, you know, what I'm looking for in the system? And that has been really the disconnect that has been there. So silence on both ends, I think, both for different reasons.
And we were talking before we started taping, it's not the same thing for children. If something happens to a child, they take them to hospital. People ask questions.
Absolutely, right. And I think it was, and this is where, for us, you know, we have to, like, so in orthopedics, for example, you train for many, many years, 10 to 14 years, and you become an expert, and people come to you for a specific answer. I think when you are going in an area which is, you know, an area different from your core training, you have to become a student again. You have to embrace the fact that you've got to surround yourself with people who are going to be able to help you and think through this. So it would be errant to think of what has worked or what we have created policy for children, which is any child under the age of 2 with an unwitnessed injury, specifically coming in with a broken bone, and we talk about sort of the femur bone as being one of them, immediately has a series of events that occur. You know, it's just mandated that in the hospital system there will be social services called, and there will likely be, you know, an investigation of sorts, because that is, you know, is there to protect the child. Extrapolating that though to an adult woman who comes in with an injury and making the assumption, or even if she were to disclose to you that, you know, this is due to you know, a partner of mine who's inflicted this on me, for us to do the exact same process, which is saying we will mandatorily call, let's say, you know, police, or will mandatorily make arrangements to call social services, may be difficult. It may be more challenged. And as I've learned from Clare and many others, that at the time of disclosure, which is the big fundamental issue, the risks for women getting abuse increasing, or the danger to them, is high. So we have to be particularly careful about how we manage that moment. And quite frankly, we have to be in it together to make sure that we do what's right for her and her family, and quite frankly, any children that are involved.
Claire, why is this work important to you?
Well, it's a phenomenon, issue that's been going on in society for long, long periods of time, and you know, certainly I'm a woman, and certainly I want to create a safe space where women can have full participation in society. And as long as we're having women experiencing domestic sexual violence, gender-based, you know, inequities, then we're not going to create that kind of full inclusion in society. And it's important. It's important.
And why do you think there's that disconnect? You know, we were talking about kids. Immediately questions are asked, but for women, that doesn't exist? Well,
I think as, you know, adults make decisions. I think that the phenomenon is a bit different. And I think that for women, you really want to give choice around a lot of things. I think that, you know, even when you look at sort of where the World Health Organization talks about intimate partner violence, they say there's two things that are going on. There is the relationship, but there's also the social conditions around it. So we have social conditions that basically say if you're a victim, there's something wrong with you, that you've done something wrong. Also, when you're in a relationship, you want to protect your partner. You don't really want to say bad things about your partner. So there are things that sort of go on that keep people from really coming forward. And there is lots of, you know, things in recent media here in Ontario as well as across the world where when women do come forward, there's a lot of shaming that goes on for women, so they're fearful of it. And they've been met at times by healthcare providers who have, you know, minimized their experience, you know, asked them the wrong questions, or said, you must go to the police. Well, the police aren't always the answer. They're a part of the, you know, the solution, but certainly that's not the first thing that people want to run to.
I wanted to bring in some numbers into our conversation from the World Health Organization. Violence against women, especially intimate partner and sexual violence, are major public health problems and violations of women's human rights. 1 in 3, or 35% of women worldwide, have experienced either physical and or sexual intimate partner violence or non-partner violence in their lifetime. Globally, as many as 38% of murders of women are committed by an intimate partner. Intimate partner and sexual violence are mostly perpetrated by men against women. Anything that jumps out at you from that report? And this is for both of you, Claire?
Well, I think for me, it's something I've known for long periods of time. I've been doing the work for a long period of time. So some of those stats haven't changed in like 60 years. So that's
Really?
kind of, yeah, it's kind of sad.
Wow.
There have been some movements, like certainly in Canada, there are less women who are being murdered. That doesn't mean there isn't women being abused or sexually violated or experiencing sexual harassment. There have been more moves in legislation to change culture. And so what Dr. Bhandari is doing in the healthcare
How about
sector.
Ontario, sorry?
What he's doing there is really helping to change culture, and that's really what we need to do. So in countries where women have less rights, you'll see more intimate partner homicides. So really there is a correlationship between women's full equality in society and the reduction of domestic and sexual violence.
What about the numbers in Ontario?
Ontario, there's about 30 women a year who die from domestic homicides, which is far too many. They say like there's about 8% of women will report sexual violence, and we all know that that's way underreported, and certainly the Ghomeshi trial, people are questioning whether more people are going to come forward or not. There are some issues and problems within our system that keeps people from coming forward, and I will say that I'm very impressed with the Wynne government's commitment to changing some of the workplace legislation to make sexual harassment, domestic violence in the workplace, an issue that they're going to address, and some changes that they're looking at to supporting victims better.
And Mo, those numbers, anything jump out at you?
Well, I mean, the thing that comes across, which is, blatant, is that, 35% of women at some point in their life are going to have some experience with intimate partner violence or domestic violence in the broadest terms. That is a fundamental disconnect with many in the healthcare community who continue or have had misperceptions in saying, well, it's happening in the community, but it's not happening in our patients. The women are coming into our hospital. That has been the fundamental challenge that we have seen in orthopedics. And the point that Clare makes is that with intimate partner homicide it is a horrible event. I mean, with 30 deaths due to an intimate partner a year in Ontario alone, and it's despicable to see that, and you want to end that. Orthopedic surgeons, as a group, and that's why I fundamentally got engaged, is that we see women who are coming in with fractures. And if you think of the spectrum of physical violence, getting a broken bone or sustaining an injury that is serious enough to require you to come to hospital, but even serious enough to require an operation, in and of itself, from other literature and other research, is suggestive, in fact, predictive of the increasing risk of intimate partner homicide. So there is a point that we are right at that edge. So and we are there, but not a single orthopedic surgeon in the trials that we've done in the past had asked the women who ultimately reported to us, confidentially.
Do you think it has to do with if you ask somebody and they tell you, then that means that you're responsible in some kind of way?
Exactly. So some of the critical barriers in healthcare have been, one is the issue of time, which is, time and education. And quite frankly, the words in quotes is, I'll be opening a can of worms. The education experience is really fearful because I don't know what to do. And I think that has been the biggest challenge, but also is the biggest opportunity, for experts to come in and say, we have to educate the healthcare providers, especially some of our subspecialists who are going to be coming in and ultimately caring for these women for, months, if not years. There's an opportunity to do something there.
I mean, I find this quite fascinating because, I think if you're in that kind of situation, you're scared. But if you come into the hospital, your bones are kind of speaking for you. That's right. If you don't have the courage to speak for yourself. That's exactly and if no one responds, then...
Well, see, and this is the challenge. So, we make the assumption that, that a woman who's been in an abusive relationship will come in with a broken bone, will come to emergency department and immediately disclose and say, this is because in fact, what I've learned, and I continue to learn, is that the majority of victims aren't disclosing in emergency for a variety of reasons. One is they see the physician for literally a few minutes. They're not going to have follow-up care in that environment. It's a chaotic environment in most emergency. There's a lot of people waiting. It's not a lot of privacy. A lot of reasons why that might not happen. That then says, well, they get referred on to, let's say, a subspecialist, a broken bone surgeon. Now they come in and they may spend months with that surgeon. And that's the opportunity that we've been trying to say. And we're not just talking about orthopedics, but orthopedics typically deal with broken bones. And broken bones, as a result of violence, is an extreme example of physical violence. And certainly by no means encompasses, all of intimate partner violence in context, but it is a predictor ongoing and escalating violence.
Something terrible that might happen.
We should be doing something about it.
And I think what's really interesting about what Dr. Bhandari's been doing is he partnered right away with the violence against women experts, right? Because what we do know from women is, they aren't necessarily super ready to expose themselves in that way. But if they are, right, making sure the person who's asking the question isn't afraid of the answer. So sometimes women have disclosed and they see the shock on the person who's heard and they don't know what to do. So it makes them feel, again, shamed, and they feel unsafe in that situation. So by, partnering and educating, the surgeon how to manage it, but also how to refer. So even just, we've done a lot of work on stages of change. So when you're in an intimate partner violence, there's an event of a broken bone, but it's a process of change, right? Because you can sometimes make excuses for, why you got a broken bone. We got out of control. Maybe we were, fighting too much and he didn't really mean it and I fell. And so people tried to say, well, it was one incident, so it's not really an abusive relationship. But after a while, people start to see, things are accumulating in the relationship, and then they want to change. So making sure that when they're ready to disclose, that the person has the comfortability, the right response for them, and knows how to connect them with the community experts so they don't have to do it alone.
If you're watching at home and if you are in a similar situation or you know of someone, there's a number there that you can call. Claire, I'm wondering, what are some of the misconceptions people have about violence against women?
Well, they think that, generally speaking, it couldn't happen to me. I think that, quite frankly, we can all be victims. We can all be perpetrators on some level. And we have this idea of a certain look, of certain things that are going on in people's life, that if you're a professional and you can go out and be confident in the world, that somehow you couldn't be a victim. And it's simply not true. Relationships are complicated. I think that we all have areas in our own internal being where we don't feel super confident, and then the relationship just kind of, exploits those kind of things. And also we care for the person we're involved with, and they're not all bad. They have some really great qualities about them, and the women are interested in the great qualities. They're not interested in the violence, and they're trying to figure out how can we get rid of this poor little problem that's happening in our relationship. And oftentimes victims will overtake responsibility for it, and the perpetrators will take under responsibility for their behavior. So I think that's a big misconception, that somehow it's a certain person, a certain look.
And from the point of view of some work we've done surveys of surgeons across Canada, and 1 in 5, this is about 5-6 years ago now, but 1 in 5 surgeons believed that the victim does something to be a victim. So there's a lot of victim blaming, and it's a misperception that can be, education would resolve. And the other big misperception is, they can leave. They choose to be in this relationship, they can leave. And it, again, as we've learned, it is very difficult for a host of reasons. And it's a much more complex issue than you should just leave if someone's doing that to you. So those misconceptions require a considerable amount of education.
And just add to that point, in actual fact, women, when they're in the process of leaving, are at the highest risk of being murdered, right? So, and that's why when women are starting to contemplate leaving their relationships, that's when we really ask them, before you go out there, connect with, an advocacy agency.
Why is that? Why does?
A lot of reasons, because the person can control you while you're in the relationship. And so when women start to think about leaving, they start to distance themselves. They start to say no in the relationship. They're not as easily drawn into some of the triggers that will pull them back into the relationship. So the person who they're leaving is feeling out of control, right? And they're feeling really vulnerable, and they think this person is harming them, right? So we often say that she's at risk, but if you actually ask him, he's saying that she has a lot of power and she's doing things to him. So it's a really distorted kind of way of thinking, and they're losing. And yeah.
You work out of hospice now.
Yes, I do.
Are you exposed to any of this?
Violence, goes through the spectrum. So if it's there in your relationship at any aspect and any time in your life, it will show up in hospice and palliative care as well. In aging, we see elderly abuse that's going on and whatnot. So yeah, it absolutely does.
And Mo, you did a global study a few years back looking into domestic violence.
That's correct.
What did you find?
So, I'll give you a précis as to why we had to do this study, because you would think that the data that you presented already, is compelling, right? So why aren't we doing something? And surgeons, as I've realized over time, are very data-driven, but they're data-driven to their personal circumstances. So the study we did, called PRAISE, which is a large study of just over 2,900 women across Canada, US, and Europe. And we also had a site in India where we just simply had women come in and through a confidential process, we would just ask them questions about, their experience or their history of intimate partner violence, and more importantly, whether their current visit was due to intimate partner violence and what had been the response to that. And the response was, as you would expect, that 1 in 3, as you've already shown, women came in saying that we've had a lifetime history, in some form or other of within the definition of domestic violence. But the other point was 1 in 6 women came in and said, we've had physical violence that's associated with that within the last year, and 1 in 50 came in and said, we're here because of that. When we asked them, well, how many of your surgeons had asked about it? 0. So, so that's a disconnect, right? Now, if you put it in perspective, let's say to an orthopedic surgeon in Ontario, who over a year will likely come across somewhere between 900 to 1,000 women with injuries. So they come through the clinics. It's over a year. That's pretty standard. Mm-hmm. You'd anticipate that 300 of those women will have had some experience with intimate partner violence. 150 of those women will have had physical violence associated with it, and 20 to 25 women will actually be there because of that violent episode with an injury. Now, that's a big opportunity. For a single orthopedic surgeon, that is a big opportunity. And what we've just been saying, which is increasing, like that type of violence is an increasing predictor of homicide. So we are really the second opportunity, to do something. And that is why it's an obligation. We have to do something. As a group, we have to get educated and we have to find ways to, as you said, identify and be there when we can.
What do you think men can do to engage in this issue?
Fundamentally, stand up and speak out. That's been the, part of the Mentor Action program, has been engaging men to, first of all, acknowledge that gender-based violence exists and that the violence against women is also a man's issue. And secondly, get out there and be an advocate, a strong advocate for women, and also an advocate to help educate men. And that's really been what the point is. You can't stay silent in this. Do anything but remain silent. Has been the focus.
And I think what Dr. Bhandari has been doing is really great, is that you can address the individual, which is very, very important, but he's doing culture change, right? And we need both.
What does that mean, culture change?
Culture change is so he's opening up orthopedic surgeons to this idea, and he's standing against, a whole association that's basically, this might not be our issue. And he's leading the charge to change that culture. So yes, because now I have the data to show you this is happening in your clinic, and this is an indicator-based reason why you would want to get more educated. And one of the other things that he hasn't spoken about here is he certainly got it in the Canadian Orthopedics Association definition that this is part of what we do, but also in the final exam for orthopedics now, he's actually got a question about domestic violence that's actually in before you become an orthopedic surgeon. So he's actually changing the culture of orthopedics in Canada, and we're getting better surgeons as a result and better experiences for women when they come forward. Because a woman should be able to come forth in any of the intersection points in her life where if she discloses, that person is educated and connected and can provide her safety.
But as you know too, ma'am, change doesn't happen overnight. And when we even look back at what happened with child abuse, the first paper was out in 1962, but it wasn't until 1975 until there was actually legislation that mandated that and policy changes associated with that. When I think of what we're trying to do in orthopedics and healthcare, it's got to take many people to take many steps towards getting to where we want to go. But every step is a step in the direction we have to go.
Now, given all the different systems that are involved in this issue, we're talking about the police, child services, healthcare providers. To what extent is everyone on the same page when it comes to domestic violence or gender-based violence?
I think that we're still moving in a direction to improve upon that piece. There's lots of new legislations, like police have protocols, child welfare has protocols, the education system has protocols, we have new protocols in the workplace. So there's a lot of things that are moving forward. In Ontario, we have the Ontario Death Review Committee, and every year they look at homicides and domestics, and they come up with recommendations. And one of the really clear recommendations is making sure all those systems are talking together and connecting, right? So that the victim's experience is positive, but also where you might be intersecting with the perpetrator, in one of those systems, you also want to create change for that person, right? It's not just about saying this person is bad and we throw them away forever. We really want to make sure that we're changing that person's behavior and monitoring and making sure the change is happening, because then as a society we'll all win in the end on that.
I mean, I think it does. I mean, it takes many of us. And so for the healthcare sector to think that they can solve this problem on their own or even address it is you know, it would be a fruitless effort. And I think you have to get experts across. And the thing I've noticed the most is the willingness of all the sectors to come together really with a meaningful discussion, and not just to meet, but really meaningful discussion. And I've been particularly, you know, just I guess impressed with our own the healthcare sector's commitment to trying to do more. As I mentioned to you again, the Canadian Orthopedic Association, 99% male orthopedic surgeon, just it is that demographic. And to see what we've seen now because of a position statement of the Canadian Orthopedic Association, but more importantly, emails that come to me daily from surgeons saying, you know, I have a situation and I just want to let you know that, you know, this is what I did. And they're just sharing they're sharing experiences now that they weren't sharing before, which means that we are making progress, which means that we're closer to where we need to be.
Mo, Claire, thank you so much for being here and also for providing a voice to a lot of people who don't have one.
It's an honor to be here.
Thanks
Thanks so much.
Thank you.
Help TVO create a better world through the power of learning. Visit TVO.org and make a tax-deductible donation today.